Okay, Nick, thank you so much. Thanks for having me. Hi, everyone. Peter Antevy here from South Florida. I hope you guys are all hanging in there. It's been obviously difficult times for ourselves and our families and our communities. And I appreciate the ability to kind of zoom in to into your homes or to the firehouses, wherever you guys are currently at this point in time. My background, like Chief said, I'm a pediatric ER doc, converted to an EMS guy about 10 years ago, where really the field of EMS changed my life significantly. And really, I love being in the field of EMS, and it's really kind of my main focus nowadays. And so I want to focus this presentation on two things. Number one is COVID related MISC, which we'll talk about. And then I'm going to translate that into if that patient goes into cardiac arrest, what are some of the important things to understand within the cardiac arrest paradigm, if you will. So let's get started. And I know we have an hour, so let's see if we can get it done in that time. So as Chief said, this is my disclosure here. So as far as Antevy, you're not going to hear about that in this presentation today. So here's your case, right? It's 2 o'clock in the morning. You get to this little child, and he's 2 years old. Oh, sorry, too many clicks. Child's 2 years old and not looking well. Okay, you can look at the image, and again, we always talk about that PAT assessment. I call it the blink assessment. Right when you walk in the room, you look at the kid, and you have an assessment being made in a very rapid fashion, whether you like it or not. And most of that is being made by visual cues, auditory cues, but the assessment obviously is very, very important. Now, clearly with this kid, you see that his position is kind of laid back, arms down to his side. He's not really fighting at all. You can see obviously the eyes look a little sunken. They're not really wide open like a 2-year-old would be when you walk into the room. And then obviously this is a 2D image, and you can't see how the kid's breathing, but what's obvious to everybody here is the child's rash. And so you can see that he's got a facial rash. It looks flat, but then in some area you could see that it looks a little different in certain spots, maybe raised in some areas. You're kind of taking in all these cues. And this particular kid is breathing a little fast, but it's not really noticeable. He's not retracting. You don't really see much congestion. And when you start to get near the kid, he starts to get very frustrated with you. And you try to get some blood pressure and heart rate and so forth, simple vital signs. And you see that he is tachypnic and he is hypotensive, right? So he's lower than the minimum acceptable blood pressure for age. And so you all know how that formula works. It's 70 plus 2 times the age. So 74 at a minimum. He's lower than that. One quick point on blood pressure: don't depend on the machine all the time. You can do this without stethoscope. You can do this without your automated blood pressure coming off your monitor. All you got to do is put a blood pressure cuff around the kid's arm. I know some of you know this, and sorry about that, but put a blood pressure cuff around the kid's arm. Feel the radial pulse. Inflate the cuff until you cannot feel the pulse any longer. Start to leak out the air, and the first moment you feel that sign of a pulsation, you look at your dial there, your gauge, and that is your systolic blood pressure. It's recorded as that number over palp. So we can't get a diastolic because we don't have a stethoscope. So really the most important number that you can give me if you're coming to my emergency department is, I got a 2-year-old tacking away at 180, BP 70 over palp. Done. I mean, I know where we're going here, which is not good. A lot of people, if you look at the data, don't even do this aspect, and they kind of chalk up the heart rate to, oh, it's 2 o'clock in the morning, oh, the kid's upset with me, or it's cold outside, or he's sick anyway. And so you have to understand that there are ways of understanding what the true heart rate is, and then being savvy enough to understand how to get a blood pressure. No excuses, because if you miss a kid who's hypotensive in front of you, every minute that goes by is a minute that he will deteriorate and then end up going into cardiac arrest. And if the kid is already hypotensive, they're already falling off the cliff, right? There's no more room for them to kind of stay well. They're falling, right? So here we have a child with a rash. You can't see the kid's eyes, but the eyes are a little bit red. You can't see the kid's tongue and lips, but the tongue and lips are a little bit red. The rash goes all the way down to the hands and the feet. And then you do a temperature, and your temperature is elevated, and you're tachycardic. So if you bring this kid into any pediatric emergency department for the last 30 years, this kid automatically screams of one disease, right? And that one disease is called Kawasaki disease. So let me kind of first take you to what Kawasaki disease is by this image. The disease of Kawasaki was first reported by Dr. Kawasaki in Japan back, I believe, in the 1960s. He saw all these kids who were having red eyes, red lips, red swollen hands, swollen feet, temperature. And then there was a lot of laboratory findings, which we're not going to talk about the lab today because it doesn't relate to us in EMS. And all these findings got better over time. But there was one reason why Kawasaki disease was important not to miss. And the reason is because if you don't catch Kawasaki disease and treat it in the first 10 days, the kid ends up getting coronary artery aneurysms. So the arteries that feed your heart would swell up in certain areas. You would get coronary artery aneurysms, and you end up having heart failure in a child for the rest of their life, right? Severe stuff. So they finally figured out that this Kawasaki disease, if you think about it, it's a disease of the small blood vessel. Look at the eyes. They're red, but there's no discharge coming out of it. It's a very, very important thing. So I got 3 kids. When they got conjunctivitis and I see the goop coming out of their eyes, that's not Kawasaki's, right? But when you have a vascular disease or a disease that's causing inflammation to the vessels everywhere, eyes, lips, tongue, hands, everywhere else, right? Even if you look at, the heart, right, on the coronaries, for boys and girls at the tip of the penis or tip of the urethra, it's red. It's anywhere there's a small blood vessel, it's causing the problem of inflammation. So again, all the inflammatory problems go away, and the treatment was to actually give something to these kids with Kawasaki's to make the inflammation go away in the heart. And to do that, we gave immunoglobulins. Basically, it comes in a bag. You give it over 6 or 12 hours, and next thing you know, suddenly all the inflammation goes away. We give aspirin. We're not going to get into the aspirin part today, but there was a very regimented protocol for Kawasaki. So I trained in California, as you heard the chief said earlier, trained in Pittsburgh. And California was like a mecca for Kawasaki's. We saw it all the time. We know what to do. We treated them, and they all did well, okay? What we never did see with Kawasaki's, well, I should say very rarely, if ever saw, was kids coming in hypotensive and dying, okay? Every once in a while, you may hear of it. And so now let's move into the world of MAEMSC. Well, what I'm about to talk to you about in MAEMSC is the same exact thing that we've seen in Kawasaki's for all these years. So this picture, plus, for some reason, we're going to add in the badness of it, which is going to be shock, hypotension. And the way I want to go through this with you is with a very, very, very detailed paper that just came out in New England Journal of Medicine a few days ago. So there couldn't be any better time than today to review a paper that just came out literally on June 29th, right? Where here we are colored. So this is like maybe like the fastest presentation I've ever done on a topic where the paper came out days before the presentation. So I'm not gonna take any credit for that. That's just sheer luck. So twice in this presentation, I'm gonna give you a QR code. You'll take out your phones and you'll actually get the entire article. And the reason I'm doing that, because I want you to read it. It's packed full of great stuff. And I think that we all should understand what this thing is, especially because it ain't going away, okay? It's not going away. So what happened was, the reason why we're talking about New York State is because obviously New York got hit the hardest, all the Europeans coming over, they had no idea what was going on until it just hit them hard. So we have the data from basically one state with respect to MAEMSC. So what I want to do is I'm going to go through I'm going to go through this article in pretty good detail to talk about the data. And I want you, as I'm going through this, to get a picture in your mind of what this kid looks like. And you'll never, ever miss it again. You'll never, ever miss it again. And so let's kind of go in and we'll talk about it one step at a time. Let's talk about the ages. So let's see here that this study looked at 99 children, 95 of which had confirmed multisystem inflammatory syndrome in children, and then 4 of them had suspected. I'm not going to go into the whole diagnosis and so forth, but I've already told you most of the diagnostic criteria, which is what you saw. But then they said, do these kids have COVID? Now, what I'm going to tell you now may be, one of the most important things with respect to this disease is that the kids who get MAEMSC don't actively have COVID. I should say that the COVID is not itself causing the MAEMSC right now. This happens weeks later. So what you will look for in these kids is not the PCR, even though some will be positive, but you'll look for the antibody, right? So it's almost like today is, we're in early on July. Let's say a child is sitting at home today with COVID-19, little runny nose, cough, fever, and the doctor says, you have COVID-19. They will get better, completely resolved. They're playing in the playground, everything's great, everything's great. And then all of a sudden, weeks later, they suddenly get this ramp up of redness in the eyes, face, skin, lips, tongue, and then potentially the hypotension. And when you look for the virus itself, the live virus, it's gone, okay? Why I tell you that is because when you go to these kids and you're looking for the respiratory stuff of COVID, you're not gonna find it, right? These kids may be breathing fast, but it's not because they have a respiratory disease. It's because they have an inflammatory disease that's causing them to have fever and cardiac problems, and therefore they're tachypnic because of that. So very, very important. Let's move into the age categories here. You can see that male, female, 50-50, not, it doesn't discriminate if you're boy or girl. You can see that the ages, and again, I don't know about the cases that you guys are seeing there, but you can see that the ages, a majority, not a majority, but more are in the 6 to 12-year-old range, by a small percentage, but you can see here that, more than 10% are in the 6 to 12 compared to the 0 to 5 and 13 to 20. So again, we've seen it in infants, we've seen it in teenagers, but as I'm going through, look at these 3 age categories, because one of these age categories will be sicker. Don't know the reason for that, but let's start going here and going to the next slide. Oops. Okay, let me just do this. Okay. So actually, let's go back. So let's start from the top. This is important. When you look at were these kids positive on the PCR, you could see that only half of them were. But did they have antibodies? All of them, right? You can see 99 except one. 99% of the ones who they tested for antibodies. So this is a late disease. It's not an acute illness that occurs with COVID. Very important. Next one. What about race? You can see here that an equivalent number essentially of white and black. Interestingly, the Asian number is only 4, even though Kawasaki's initially was described in the Asian population. But again, it doesn't discriminate. But here, just in the New York population, right? That's the population that was being looked at. That's what it was. And then at the bottom, the coexisting conditions, you can see that a pretty good number there had obesity. So a third of these children had obesity. What does that mean with respect to why they're getting MAEMSC? We don't know, but we do know in the adult population, obesity is another cause for badness, right? So there is, is it matching up a little bit? Yeah, a little bit. Okay, now let's start going into the symptoms at admission. Now, when you hear symptoms at admission, think symptoms at the house when you go and get that 911 call. Very important stuff. So all of them will have fever or chills. Now remember, this fever or chills has nothing to do with COVID-19, the virus. It has to do with inflammatory. Again, it's important. Not that it'll make you feel any better, but if you're running on a kid who has MAEMSC, less likely that they're actually going to give you the virus because they've had it weeks ago, right? Now this is a whole nother problem that's caused due to the virus sequelae afterwards. The GI part of it is pretty important, right? So 80% of them have something, abdominal pain, nausea, vomiting, or diarrhea. We, in my protocols down here, early on, we were told, hey, GI, not just for adults, not just for kids, but for adults. And so we include in our EMD, we added in GI symptoms because we knew exactly that people were coming with GI symptoms with COVID without the respiratory stuff. So remember fever, chills, and then remember the GI symptoms. And then 62% will have the dermatologic findings. So what does that mean? When you're looking and you're evaluating for MAEMSC, 2/3 of them will have skin manifestations. So now we're coming up to winter time. I mean, we're going to get through summer into fall, and then the flu is going to be around, and other viruses are going to be around, and you're going to say, fever and chills. Well, what do I do with that? Well, fever, chills. Do they have any GI symptoms? And then you look for the rash. Once you start putting those two together, there's no excuse to start missing, at least to consider these things, even though I'll raise my hand and say, all of us in pediatrics have been fooled because Kawasaki's and now MAEMSC was always very far down on the list, right? We have 100 kids in the ER with fever. None of them have Kawasaki's. Another 100 kids with fever. None of them have Kawasaki's. And then the next day, you have that one kid who comes in with a rash and a fever, and your brain doesn't automatically jump to Kawasaki's, or in this case, MAEMSC, now that we're calling it different. So why I'm telling you that is because you actively have to think about this in order to remember it. I don't care how good you are, how smart you are, for some reason, when you're at the home and the kid's screaming and crying, you just want to get them to the hospital, we tend not to look at the scan, and then the MAEMSC diagnosis goes down to the bottom, right? That's just human nature. What else? Look at the eyes. 61% had any kind of eye or mucous membrane, but 56% had conjunctivitis. Very important. When you look at the eyes and you say, whoa, they're red, the next thing you say to yourself is there any discharge coming out of the eyes? If the answer is no, you're onto something here. If you have all this stuff coming in the eye and the eyes are caked together, that's not Kawasaki, or that's not MAEMSC. And you notice I'm using the two terms together because I kind of grew up with Kawasaki, we're just seeing it all the time, and now we can't call it Kawasaki anymore because it's not. It's got more badness to it. What else? Now going lower on the list, headache. So again, this is not going to be a clincher by any means. Just another thing to keep in the back of your mind, and even less of a thing is body aches. Musculoskeletal issues. Again, It's down there at the bottom. And then here we go, upper respiratory. I told you already that the COVID is gone, right? The COVID happened weeks ago, so they shouldn't be here or calling because of the respiratory shouldn't be like the main thing, meaning like a true pneumonia or retractions. If they're breathing fast, which they will be, it's related to the inflammation, related to the fever, related to the hypotension. I think a lot of people miss that, where people automatically think that if you're breathing fast, you must have pneumonia. No, you're probably acidotic. You're trying to breathe out that CO2. And so basically, you don't have retractions, you're just breathing fast, right? So so this is important. Like this should be the image that you have in your mind over the next, let's say, 6 months. If I go on a run with a kid with fever, chills, some diarrhea, abdominal pain, and a rash, I mean, that should be automatically thinking MAEMSC. Hey, let me check a blood pressure with this kid, right? Let me start some IV fluids on this kid. Let me give this kid some push pressure, or start an epi drip if I have to after giving fluids. So the basics don't go away here, right? There's nothing magical about treating this kid versus treating a septic patient, right? EMS is, that's what we do. We treat what we see, and that's very simple to do. Let's go now and look at the kid age groups, and this is where the rubber hits the road here. You can see that the percent of patients is listed in the boxes, and the deeper the box color, the higher the percentage of patients. So let's start out with the most important one, which is the myocarditis, which is right here, the fourth one down. And then swing your eyes all the way to the right, and you can see that the kids who are older, 13 to 20, 73%, 6 to 12, 50%, 0 to 5, 38%. That's important because we now know, based on this great data set, that older kids are more at risk for the badness, right? Let's start from the top. Skin findings, they go away. GI findings, not a problem. Are we going to label it Kawasaki's or atypical Kawasaki's? I think that doesn't matter anymore, right? But I mean, either way. But the fact that they have myocarditis in such a very large number as you get older is important. So what does that say to you? It says fever, chills, abdominal pain, and a rash. Check, check, check. Okay. How old is this kid? Oh, he's a teenager, 13, 15, 16. Blood pressure is again, those are the kids who, by this data set, are going to be the ones who become hypotensive, who need fluids, who need pressors, who need the ICU, who are at risk for death. Okay, so I hope now you're kind of getting the picture of MAEMSC in your mind's eye, and I'm going to keep kind of harping on the fact that you really have to think about this when you're on scene, because if you don't think about it, you will forget it. I've done that many times. Okay, let's go to the next one. Vital signs. This is important. Can't say enough about vital signs in kids. You've heard that from every person who talks about pediatrics. The characteristics. Look at overall. They're all tachycardic. The tachypnea is high too, but look to the right. Look when you go to the 612 and the 1320. They're more tachypnic. Why? Because they're sicker. They're not tachypnic because they have COVID in their lungs. They're tachypnic because they have inflammatory problem everywhere in all the small vessels of the body, and they're having a problem. Look at the hypotension. This is the biggie, right? This is something we never did see to such a degree in Kawasaki. Sure, have I seen sick as shit Kawasaki kids? Hell yeah. But not to this degree, right? So look to hypotension, look all the way to the right. That's a big number, folks. Up to 50% of those kids, 46% of those kids are hypotensive. And remember, you're more than likely going to see these kids on day 4. That's when they typically get to the hospital, day 4. And again, on day 4, if you've been chugging along, and then they call because they're going to call because now suddenly the kid loses color, they don't look well, their mental status has gone down because of their blood pressure. So when you're going to get this call, you have to act. You're not going to wait for me to act in the emergency department. You're going to do the right thing. Get your vital signs, get an assessment, get an IV in, get IV fluids on board, get more IV fluids on board, and then get pressors on board. No difference, adults and kids, same exact thing. Temperature. You can see 2/3 have a temperature of above 100.4, which is 38 degrees. Again, this is not COVID-related temperature. This is inflammatory-related temperature. Very important. And then to even prove the point further that this is not a respiratory problem, their O2 sats are fine. Look at the O2 sat of less than 92. It's negligible, right? Meaning that this is not a respiratory primary problem. Very important. Okay, next, let's go to the clinical course. So when did they get to the hospital? 4 days. 4 days, you know, the 6 to 12-year-olds, 5 days. So you're looking at the range you can see is from 3 to 6 days is when you're going to get the call to come get my kid, right? ICU admission, 80% overall, 90 in the 6 to 12, 85 in the 13 to 20. Again, sicker population the older you get. And then look at the bottom. This is a tremendous number, folks, of vasopressor support, steroids, and IVIG. So I would say to you that every one of these kids should get steroids and IVIG. But I never would have thought, never, that 62% of these kids needed a vasopressor. Never. I mean, this is dramatic information. And what it tells you in the field is, don't delay, right? Do the right thing. And if you're going back and you're saying, and you're doing some CQI, and you're saying, hey, tachycardic, didn't check a blood pressure, that's a bad sign. Tachycardic, check the blood pressure, good. Didn't give IV fluids, not good. Check the blood pressure, hypotensive, gave IV fluids, great. How much did they give? Okay, they gave enough. Still hypotensive? Did we start any kind of drip, vasopressor? If the answer is no, the excuse cannot be, I was 5 minutes away from the emergency department, or I'm going to let the doctors and the nurses do it in the hospital. That is not correct. Let's do it for them. We have the capabilities. We should be doing that. Okay. And trust me, we don't do it perfect down here. Okay. I'm not trying to say that you know, we are we do it perfectly. We don't. But I'm telling you that what I now know is, you know, now that I'm, you know, knee deep in EMS, and I love it, I understand it. I know that when you're most EMS professionals in the field have a calculus, and the calculus is hospital is 10 minutes away. 10 minutes away. I still got the bag of fluids running. So maybe that hypotension, that'll get better. No. Push-pull fluid, or use the light flow if you have that. Right? That's what we use in the hospital. We get fluids quickly, and then we quickly maneuver over to the vasopressor. We're not going to sit around waiting because we don't have time to wait. So that was kind of the clinical part of it. So you know, I know that everyone's probably on mute and everything, but if there's questions, you can kind of throw it in. You know, you can put it up, and we'll talk about it later. But that is the overview of MAEMSC clinical, and I hope now you're understanding what it looks like, how to assess it, and then what the issues are between the ages, the pathophysiology of why this happens, that's not truly a acute COVID problem, and then that these kids are sick and that they need your help in the field. Okay, so let's keep moving on. So this is a great graph here, because in green, you see that this is New York, and this is all the pediatric cases of coronavirus disease in 2019 of kids who were under 21. And you can see they had a lot of cases. I think it was like 15,000 children. And you can see that here are the peak, somewhere in April of when the peak came. But then look what happened. The wave of MAEMSC didn't happen for weeks later, and then boom, it rose as the COVID cases were coming down. Very important to understand, this is not a COVID acute issue. It's a delay, it's a sequelae of COVID. Now, interestingly, and I didn't put the slide up here, back when SARS was around, you know, the initial SARS, right? There was a paper that came out that said, hey, we're seeing Kawasaki disease after SARS weeks later. It was a very small case series, but I have the paper on my computer. I was fascinated to read it because we in the pediatric side never knew what caused Kawasaki's. We always thought it was some virus. We kind of, anytime my parents said, "Hey doc, why did my kid get this thing?" All we would say is, your kid probably had a virus a couple weeks ago, and now it led to this here weeks later. Parents were frustrated. We were frustrated. You know, this is kind of confirmation that the coronavirus family, SARS and now SARS-CoV-2, is a big issue and big reason why we're getting this inflammatory issue. So I'll take a pause here to allow you to open up your phone to your camera, take an image of that QR code. That gives you the entire article. Try to, and again, I'm going to give you guys these slides. I'll forward them to Chief, and you guys can use these slides, teach other people, right? That's the key here is, let's not keep this information to ourselves. This should be, kind of put out to the world. So, Chief Adams, I'm going to stop here for a quick second to see if there's any, because now I want to move into like cardiac arrest for a few minutes, to kind of, not for a few minutes, but for about 20 minutes. So is it a good time to maybe pause, or should I just keep running through?
Yeah, let's pause right there and take questions.
Cool.
See if anybody does have questions, you can type them in the chat box.
Hopefully I didn't put everyone to sleep.
I got a quick question for you. What push dose pressor do you recommend in the pediatric population pre-hospitally?
We use epi, push pressor epi, and we do that because we already have epi. I mean, we've had some shortages in the 1 in 10,000, but it's kind of it's easy to do. I mean, the only problem with push pressor, at least in my view of the world, is that in EMS, somebody ought to make a epinephrine push pressure epi that's pre-mixed, right? They have now phenylephrine sticks. So phenylephrine is another good one, and they come pre-packaged. But if you think about epinephrine or norepinephrine or dopamine, that type of thing, in order to use like a push pressor, which would be like an epi, you have to make it yourself. I just wish somebody would make that, because you have to empty out the 1 in 10,000. You have to only use 1 ml of that and 9 ml of saline. And now basically you just made yourself like what I call a poor man's epi drip, where you're just going to give 1 ml and you're going to stop. And you're going to, that 1 ml may give you 15 minutes of good blood pressure. So what takes you 30 seconds to make, and you just give 1 ml and you stop, right? And then you can give another ml, as soon as another minute later, but more than likely that 1 ml will last you to the hospital, right? So it's very simple to do, very easy. The alternative of, putting a milligram in a 250 bag and getting 4 mics per ml and having to figure out a drip rate, very difficult to do. Not very difficult, but if you're 4 minutes away from the hospital, you're just not going to do it. So we are now really heavy in push pressor and I call that a bridge to an epi drip. So if you're ever pulling out push pressor epi, for God's sakes, make the epi drip. I mean, maybe that's more of a hospital thing as well, but push pressor epi is only a bridge to a drip, because you're gonna need it if you gave the kid epi push pressor, right? No one gets push pressor epi 1 ml and then goes home. They all end up on a drip. They all end up intubated and in the ICU, probably more than anything.
I know you have a good video too. I think it's on YouTube to show how to mix quickly. Is that still on YouTube?
Yeah. We have. If you go to Antevy YouTube channel, all of those videos are up there. Yep, there's like 20 something now, I think.
Are you able to read the questions in the chat? I'm being told that my audio is giving bad feedback in some places.
I cannot, because I only have a small panel here.
Okay, let me, I'll try to read what I see. First question is, how many symptoms are required in order to diagnose MISC? I have read 3.
Great question. It doesn't only go by symptoms, it goes by laboratory findings too. So yes, you're right that there are, fever has to be there, right? I mean, fever has to be there. So in Kawasaki disease, if the fever went away, then you don't have Kawasaki. So you have to have fever. Rash was one of those findings that, we almost always saw the rash, but there's atypical Kawasaki's that you don't have the rash. Then there's a lymph node, a larger lymph node on one side of the neck. Okay. Then, so you have you have the clinical constellation, right? But then you cannot make a diagnosis based on clinical findings only. You now have to go into the laboratory findings. So, and I didn't put that here because it wasn't nothing appropriate. But for example, CRP, right? Almost all of them had high CRP, pro-BNP, troponin, right? Troponin in children. Whoever did that? This is what we would do now to check for the myocarditis. Obviously, they all get EKGs. They all get echocardiograms. We do a urine test because, like I told you, the tip of the urethra is swollen, is inflamed because of the small blood vessels. So you don't use a catheter into the urine because you're going to miss the white blood cells. You just have the kid pee into a cup or an infant into a bag. So it's really a constellation, and if you're missing some of them, it just falls into the category of atypical. So I wouldn't hold your hat on how many do you have to have, because it's basically fever is a must, right? Because without the fever, I think most of these diagnoses kind of fade away into the background. And then it's the rash and the other findings, and then you have to tack on the other lab findings. So hopefully that helps.
Absolutely. Next question was, how do you feel about pre-hospital corticosteroids for these patients?
Yeah, listen, clearly corticosteroids works. And so I'm a big fan of corticosteroids if you just want to take a jog. I mean, I'm a big, I still haven't found a reason not to give anyone steroids. And if anyone can tell me the reason not to give a steroid, I mean, I think it's very important. Now we know in not just COVID, right? You have a decadron, but now we know it's important. It's an inflammatory syndrome, so I have zero problem giving steroids, especially if you have a longer transport time. Clearly, the steroid is not going to fix you right this second, but the earlier you get it on, the better. So if I had an MISC specific protocol, which we don't, then I would for sure have that in there. Good question.
Let's see. It says, as far as resuscitation goes, of concern for myocarditis, do judicious 5 to 10 milliliters per kilogram would still be preferred amount to start with, and then move to epi if no improvement? Question.
Yeah, that's a good question you have here. When you do an echo on these kids, they all have some component of cardiac dysfunction, and so their problem is more of a cardiac issue than it is a fluid issue, right? So it's a very, very good point you make here. In that case, that's why vasopressors are important and fluids probably less important. So I would say giving 20 cc's per kilo, I think any of us would always start with that. So 5 to 10, I think, is too small. Remember, the kid has probably been sick for days. They're tachycardic, they're breathing faster, and therefore they're further fluid depleted. And if you think of what 20 cc's per kilo is for a 10 kilo kid, that's 200 mLs. And let's see, I have this in front of me here. I don't know how many mLs this sucker is here. Here you go. So my wife is giving me vitamin C drinks. She's worried about me. But this right here is, my glasses are still on. Yes, hold on. Just had it a second ago. I believe this was 500 mLs. So imagine that, like, this much here, right, this bottle is what you're going to give a 1-year-old. That's okay. 20 per kilo, give it, right? Now, when they get to me in the hospital, I'm going to be evaluating their liver size. I'm going to probably do an ultrasound to see their IVC. I'll do all that stuff, but I personally would give Any kid I see right off the bat, they're getting 20 cc's per kilo. If they get worse, okay, I have my answer. Hope that answers the question.
Last question I see right now is MIS being seen in adults as well?
I haven't heard reports of that, but I can tell you that the treatment, it's funny you asked that because I actually called my adult ICU colleagues and I'm like, are you guys giving IVIG? And they looked at me and they're like, well, why would you do that? And I said, well, because, you know, it's Kawasaki's, that's all it is. And so I would say that you saw this case here, this paper goes up to 21. So the answer is yes, because adults really is after you hit puberty. So the answer is yes, it must exist. It's just maybe not being reported like it is in children, and it's probably much less frequent because we don't see Kawasaki's in adults for the most part.
And then finally, there's a statement, I don't know if you want to comment on it, but there's different criteria from the CDC versus WHO. That's what the definition for MISC is.
You know, I have to look at those two definitions. I don't have them up in front of me from the WHO and CDC. But I would say to you all, read this article, and because remember that the definitions come from what we've seen clinically. What this article just shows you is what we've seen clinically, and it tells you in a very graphical manner what is there the most, what is there second, what is there third. And so here's what I would do, and I'll do this afterwards once we're off the webinar. I'm going to go look at the CDC, the WHO, and then I'm going to compare it to this article because remember, New York reported the first case of this in March, I think on March 13th. Somewhere around there. On March 14th, the CDC came out with their description, right? So the description follows the clinical findings. This article shows you what exactly happened in 100 people. That's a lot. So I would kind of just compare the three, but I wouldn't get hung up on the definitions unless for some reason they're greatly different, which I would have a hard time believing that they are.
Excellent. Thank you. We have about 15 minutes left in the hour, but feel free to take your time. I know you wanted to touch on cardiac arrest as well.
Yes, perfect. Okay. I mean, if there's no other questions, I'll just quickly, I may kind of skip through some slides just to kind of get to the final point. And this is why it's important. These kids will go into cardiac arrest, right? And whether they have MISC or sepsis or asthma or whatever, it's cardiac arrest now, right? It is cardiac arrest now. There's no like magical way to treat cardiac arrest here or here. It's the kid needs perfusion to the brain, a kid needs perfusion to the coronary arteries, and once we fix that part of it, and of course we need an airway, and once we fix that part of it, then we can get to fixing the MISC, right? So I really want to enforce that fact here. So you know, kids don't do well. They don't do well. The data has showed it out of hospital, and that actually comes right from here. So you could see that it's flipped around. Cardiac arrest in MISC will happen less in the little ones and more in the adult ones. So just understand that there is a little bit of a difference here. Probably better to work an arrest on an older kid than a younger kid, just for ease of kind of getting around the kid and that type of thing. For most people, it's meant for the two. So I'm going to skip through some slides here, Nick, because just for the sake of time. But in the adults, we know how to do it. Heads up CPR is what we do now in Palm Beach County. But forget about heads up, high performance, right? If you're not doing high performance CPR on scene with a child in cardiac arrest, then you're not doing them any favors. I have to say, like, you know, years ago, and when I came to Atlanta last year, I may not have been as adamant. I'm pounding my hand on the ground to say, treat these kids where you find them, right? There's no running anymore. There's no more running, because when you run, you're doing the kid a disservice. And you may think you're doing the family a favor, you're not. You may think you're doing yourself a favor, you're not. Do the kid a favor and treat the kid like an adult. That's it. End of story. And I like putting up this image because if the bystander and the telecommunicator aren't doing the right job, then the game over. And then if EMS doesn't have a pre-plan and you're not staying on scene, game over, right? And that's what happens in kids. We've seen it over and over and over again. And I'm not going to stop until people understand that that's the truth. Okay, so that's just, you hear I'm getting a little upset at it because we now have so much data and so much knowledge that it's time to wake up and smell the coffee. Okay, and I have a cup of coffee for you guys right here. It's cold and I don't smell it anymore. So let's kind of skip through these. Let me just kind of get to the end of it. Sorry. People are calling me left and right here, sorry. So what I wanted to harp on is that these two people should be treated exactly the same, okay? There's no difference in the world, and here's why this is important, and I think I spoke about this last time, and I saw you guys, but if someone didn't hear this, is that if you can't get to closure, then you're done. You're in trouble as an EMS professional, if you're a nurse listening or a doctor. How do you get to closure? Meaning, how are you able to tell yourself, good job, Peter Antevy, good job, Nick Adams? How do you tell yourself, we did right? It all goes to the first two quadrants. So en route to this MAEMSC call, 5-year-old fever, known contact to COVID, whatever, you should automatically be saying to yourself, okay, this could be an MAEMSC. When I get to the scene, I'm not going to run. I know exactly, I'm going to make an assessment. I'm going to do some vital signs, make sure I get a blood pressure. I know that a 5-year-old needs 2 cc's of epi. I know cardiac arrest. I know how to bag a patient. Done, right? So the en route portion is important. Oftentimes in kids, we kind of don't do it right. Then the on-scene part, again, I've harped on this already, so I'm not going to keep going over it. We do it well for the adult, but we tend to run for the kid. So then we add in a debrief for the adult, or for the kid, because, we want to know, what could I have done better? And the important part of this slide is that, what could we have done better? You're comparing yourself to yourself. When you were running an adult code yesterday, and you blew it out of the water, it was perfect. And today, you run a 5-year-old code, and you ran, and you were scared, you didn't talk to the family, and you just didn't do anything and not to the call. Of course, this is exaggeration, right? You're not comparing yourself to your partner or the agency next door. No, you're comparing yourself to you. I'm Peter Antevy comparing to Peter Antevy. And when that comparison doesn't match up, you're in trouble and you cannot get the closure. And so what I really want to emphasize here is that closure is important for all of us, because if you don't get the closure, you will never get the closure. Meaning that kid that unfortunately died in your care, you will blame yourself and you'll never get over it if you didn't do the right things on the front end. And that's been listed in this, what they call Resuscitations That Never End, a little op-ed that was in JAMA a few years ago. I can send this one over to you guys if you're interested. But I guess what I'm trying to say is, MAEMSC or not, treat them on scene as you would an adult, do the best that you can for them, then move on and get them to the hospital. And when you do that, and you can look at parents in the eyes and say, listen, we did everything we could for your child, that means a lot for those people, because they're never going to see you again, but they're going to know that their child did not die in vain, that you did everything you could for them, but you got to tell them that you did that. You can't just run away from them. So that's kind of an important thing for me now, right? I've been doing this for 21 years, and I did it wrong for 15 of them. So now I know better, and I'm not embarrassed to say it. So we're not going to talk about layperson telephone CPR, but we did a little bit harp on EMS CPR here, and that's kind of what I think we're here to talk about today. So the questions, actually this relates to the layperson, which we're not going to talk about today, but let's talk about the bystander. If the bystander is not getting CPR, look at what happened. So if you live in a community where they call and say, my son or daughter is in cardiac arrest, and when you get there, there's no one pushing, that kid's not going to do well. You have to go to dispatch, talk to your telecommunicators, and which I'm sure you guys are doing. You guys are a phenomenal system, right? So I have no doubt. And I know your medical directors, a few of them over there, they're amazing people. So, but when you get to a scene and you're not seeing someone pushing on the chest, you should go back and say, hey, why is that happening? Let's listen to the call. Because if there's no bystander CPR, look at the outcome. There's bystander CPR only after the 911 call, look at the outcome. If there's bystander CPR just because the people know that the kid is not breathing normally and they're not conscious, look at the outcome. So part of this is us, part of this is before us, right? And so this is the concept of no-go. You guys have heard of this. Right when the call taker or the telecommunicator gets a no to these two questions, it's go. Very simple. And the American Heart Association says that you should get to recognition of arrest, which is those two questions, within a minute, and you should have hands on chest within 2 minutes. And the beauty of this is you guys are on the CARES registry, right? All you got to do is go to your dispatch center, your communication center, and say, hey, we have this thing called CARES. There's a dispatcher assisted CARES module. Can you do me a favor? After the audio comes in, can you add 3 times to this software program that we have access to for free? I think the state pays for it, and at least in Florida they do. How long did it take the dispatcher to recognize the need for CPR? When did they begin instructions? When did the first compression happen? And then, all of a sudden, at the end of the quarter, not only are you getting your cardiac arrest data, but you're getting your CARES data. And now, as a medical director, I could say, how's my communication center doing? Oh, wow, look at the times here. And then you can start to really understand that it took here, in this particular case, 2 minutes to get to CPR instructions. And you took here 3 minutes to get the hands on chest. That's too long. That's too long. Now, if you didn't know that to be true, you would never go fix it. In Broward County, I hate to say this, we were at 5.5 minutes hands on chest time. Who's going to make it there? Nobody. Nobody, right? Or very few. So again, there's a lot of audio that I have that you can listen to, but I'm not going to make you go listen to it now. But when you listen to the call, you can see how quickly this call taker jumps right to CPR. Beautiful, beautiful thing. So we only have a few more minutes. I'm gonna talk about really, in order to do well for the kid, en route to the call, just have a plan. Know at least the epi dose and the airway size. When you get to the scene, talk to mom and dad. Let them know why you're staying. Do high performance BLS, and then give early epinephrine, meaning within 5 minutes of your arrival. If you could do a few simple things, you don't have to buy anyone's system, you don't have to have an app, nothing. You can do all this today. You just got to do it, right? You just got to do it. And so I have a little video here. I'm not going to show it for the sake of time. It's on YouTube as well. But this is kind of how we do it in Palm Beach County. This is how we do it in Broward County. This is kind of knowing what to do before you get to the scene is paramount. High performance CPR, you guys, this is all basic bread and butter stuff. So I'm going to skip through this real quick. We tell people exactly where to put the gear. So you're going to see this here. You can see the video running. That didn't happen by mistake. Everyone put their gear down on purpose. And there's good data on that, right? This is the data that shows that where you put your equipment matters, right? I have this paper if anybody wants to read it. Then you have position number 1, right? Very simple. Start CPR until the monitor is charged. Then we do our first quick look. We dump or we shock, and then that 2-minute compression starts for the first time. Position 2. That person has a very simple job. Put the patches on, charge the monitor. Once the monitor is charged, shock or dump, and then you put the IO in. We use femoral IO, and then you give it a dose of epi. Very simple. And then at 2 minutes, you switch with number 1. Okay? I mean, this is as basic as it gets. Airway person, we use 2 big breaths. Everybody, adult and kids, gets 1, 2 big breaths. I use the word big on purpose. I-gel goes in, and then we go to asynchronous ventilation. Very, very simple, very easy to do. And so let's say this kid has MAEMSC. I mean, hopefully he wasn't swimming. But you can see here that this is my crew in Palm Beach County. They're not leaving. They're not nervous. They're not screaming. And someone is talking to the mom saying, you're probably wondering why we're not going to the hospital. We're not going to the hospital because we're going to spend the next 5 minutes here on scene trying to get your child back to life. And just in the last couple of minutes, I'll say that there's plenty of data to prove that this is the right thing to do. There's plenty of data to prove that early epinephrine, meaning within minutes of arrival is the right thing to do. Paramedic 2, everyone said, oh my God, epinephrine given to adult cardiac arrest victims didn't really work because then they all did poorly and only a few of them came back to life neurologically normal. What they didn't tell you, if you didn't read this article, is that it took 21.5 minutes to get them epinephrine on board. That's too long. So here we go. High performance BLS care with a focus on your cardiac arrest high performance care. Then you put an IO in and you give epi, and you got to do that within 5 minutes of arrival. If you can do that, you're good. If you just get a pulse back 30 minutes later, don't celebrate, because those kids, based on this study, end up with brain damage, they herniate, and they die. So just getting a pulse back 30 minutes later, not good. So to kind of end, I would say here that arrive on scene, bag, compress, put an IO in, give epinephrine if they need it, and then you can start to consider what to do next. So going back to our case that we started off with, a 911 call, you know that this kid, when you look at him, he has fever, he has a rash, his eyes are red, oh, he's tachycardic, oh, he's breathing fast, oh, he's hypotensive. Okay, let's stop an IV or an IO, give him IV fluids, consider epinephrine, a push pressure epinephrine or an epi drip or norepi, whatever you carry, or dopamine. And then let's get this kid to the hospital, okay? Don't just wait for me, because by the time you get the kid to me, I gotta then, do all that stuff, and it'll take me 20 minutes to get that same thing that you could have done before. So remember these symptoms here, and I think that you'll be very good. And I think right at 2 o'clock, I'm gonna go to the next couple of slides here that this could be done, right? So this is not a girl who had MAEMSC, but this is from Oregon. This is a girl that they coded, Ben Fire out of Oregon, coded this girl for 40 minutes in the house. The 911 call is just the most impressive thing in the world. They didn't wait for anybody else. She got discharged from the hospital. You can do it. This is Captain Peter Hosick, one of my favorite people in the world, because he made it happen. And then, there's other data that now Polk County has shown. And look at the difference in that the time to epi was very important. So high performance BLS, early epinephrine, kids come back to life. And that paper was published a year ago now. And then last but not least, I'll end on this, is that if you're on the scene, don't ignore the family, tell them why you're staying, and then at the ER, go back and tell them what you did, and then that's about it. So I'll end with, treat kids like little adults, MISC or not, make this your today. And then I'll leave my email, my personal email. I'm on the Twitter. That's where Nick finds me sometimes too. And then you can use your phone again if you didn't catch that article from before. And 2 o'clock and 1 minute, done.
That was pretty good, because we didn't actually start until 1:01, so that's 60 minutes on the dot. Good job.
All right.
Do you have a couple minutes to take any questions?
Sure, absolutely.
All right, any questions for Dr. Antevy? Feel free to stick them in the chat, or if you want, you can unmute yourself, or if you're on the phone, dial *6 to unmute. I saw a couple of comments. There's a pediatric intensivist here with holding off in steroids until the ED. We're a system that's fairly close to the hospital at all times.
Yeah.
Then let's see, I'm looking here.
That's fine. I think that's fine. Yeah.
They also agree with small fluids if you're concerned for poor cardiac function. Always can give more. Start with 5 to 10 cc's per kilogram and reevaluate.
Yeah, listen. I think there's many ways to skin a cat. You have to be you have to be able to assess patients appropriately, right? So if you're not palpating for a liver, if you're not able to listen to lung sounds, if you're not able to make that assessment, but I honestly think that if you're going to overload somebody, you always have the ability to manage your airway appropriately. You always have the ability to give fluids, but I personally never thought that 20 cc's per kilo, at least as the first initial bolus, because remember, 20/20 hindsight, right? After you see the kid has myocarditis, you're like, oh, you should have done that. But in EMS and the emergency department, we're not that smart. At least I don't feel like I am. So to figure that out.
And then also added, dopa is an option. It's pre-mixed bag. Start with 10 mics per kilo per minute. I know we don't carry dopamine anymore, but
Yeah,
I'm not sure.
Yeah, dopamine's gone out of favor. And the bottom line is that when you look at dopamine and you get a start at 10 mics per kilo per minute on a 1-year-old kid, if you look at the drops per minute or the mLs per hour, that thing until it gets in, and then you got to start titrating it up and down. It's probably better off somewhere else, but it's gone out of favor. Dopamine is at the bottom of the list now for pressors anymore.
And then our state director brought up a good point, and it actually was one of the things that encouraged me to host this WebEx. Was he said EMS agencies should really look at their data at biospatial, and you can see any potential MAEMSC cases based on the calculated syndrome. And actually that tool is extraordinarily useful if you have access to it. We were able to see that we've had 5 to 6 cases of MSIC when I called Dr. Antevy about 2 weeks ago, and then I started to get some reports from my crews of what they were seeing. So yeah, biospatial to see kind of how much MISC you have in your county is very helpful.
We use it here. Yeah, we love biospatial. Yes, great point. The medical director. Yeah.
Let's see, there's one more question. There's recent data stating that past the second round of epi, survivability drops significantly in adults. Oh, that's a good question. Is there evidence for this in pediatrics?
Well, that's a great question. Remember, adults and kids have different reasons for the cardiac arrest, right? Adults, shockable rhythms. We've removed epi from that algorithm altogether here in South Florida. And so kids, on the other hand, they're primarily going to show up with asystole, right? 80% of the time. And so kids, if they get epi early, my feeling is that they have a better chance of survival. What I tell my crews is the following: leave after the 3rd dose of epi has been given, because if you haven't gotten the kid back by then the odds are not that good. But what I found more to be true is that the way that you perform your BLS is so important in kids, because remember that if you're a leaner, right, and you're not getting full recoil, the coronaries are not filling up because you're not letting the coronaries fill up, right? It's pushed to the brain and you release for the heart. And over again, I see people not doing the BLS right. They hyperventilate the kids, they stack the lung, the heart can't fill, and all the epi in the world is not going to work. So I would focus on your BLS care without any, kind of loss of exactness, let's put it that way, and then get your epi on board. But I think adults and kids are just 2 different animals. And so I hope I answered the question, but I see it a little differently. And the data has proven that out, that epi in kids who are in asystole, you can get them back. If you have an asystolic adult, there's not much that gets those people back, right? If you just look at the numbers.
Excellent, fantastic. Not seeing any more questions. Thank you very much, Dr. Antevy, and we look forward to seeing you back in Atlanta in 2021.
All right, well, I appreciate it. Thanks I really appreciate you, Nick, for getting this together, and I hope to get back on a plane without a mask one day. So
we'll see you. Thank you, everybody.
Okay, take care.